Okay, thanks, colleagues. I see there's quite a number of people joining us for this webinar. We are meeting quite a number of people just before we start the webinar. Just as an introduction, my name is Raymond Bila. I'm the Group Medical Officer for Clinics Health Group, and we've been hosting these webinars since the beginning of the lockdown in 2020. It's been quite an exciting moment for us as we welcome and share ideas and experiences, and also new information, medical education, as we get a variety of speakers from different fields in the health fraternity, not only medical doctors, but also other health professionals, psychologists and nurses. And also we've had optometrists also speaking to us. And so this evening we've got also that special moment that we are having another speaker joining us. If I could just maybe request that make sure that you mute yourself when you enter. And just to indicate that these webinars are CPD accredited, and all practitioners who have been registered professionally with any of the regulatory bodies need to make sure that as you log in, submit or supply us with your details. There's information that you need to supply as you register your name, surname, email address, practice number, so that that information can be then shared with the people who help us to get CPD points. At the end of the presentation, we submit all this information. And for those who are registered with the HPCSA, automatically you'll get your CPD points. You don't have to contact us. This will be uploaded and updated automatically from their side. And please note that these webinars are also recorded on YouTube as we do these presentations. Immediately after the presentations, you can access the presentations on YouTube, so that at least at any time that you wish to view or check the information that was presented at your own liberty, you may be able to do so. And so this evening we are continuing with our webinars, and we're quite excited to have one of the well-known figures in our medical fraternity, well known to most people who have gone through medical school, academic school, various hospitals. And so we are also back to COVID. It's quite a topical, quite a opportunity to discuss COVID. We've not been discussing this topic in a long time. But as you've noticed that in the last few weeks, we've had an upsurge of the COVID infections. It is not clear whether we're in the fifth wave or not, but officially we've not been told that we are in the fifth wave, but scientists do say that we are actually in the fifth wave. But you're told that because we are not having a new variant. Please make sure that you Junaid Bayat, please, Junaid Bayat, please mute yourself. And Michael Chipton. And that, because there's no, well, let me leave that to the specialist to talk about it. Professor Mathivha will talk about that and the issues of the variants or not. But the topic this evening is long COVID, the post-COVID syndrome, diagnosis, public health, and implications and management. And it is befitting that we get none other than Professor Rudo Mathivha, who's the first Black South African woman to study critical care medicine. Rudo graduated from the University of Natal, and then the current, now called University of KwaZulu-Natal, and she completed pediatric residence at Chris Hani Bara Academic Hospital before embarking on an educational sojourn at Duke University Medical Center, Durham, North Carolina in the USA. And at Duke University, she completed a fellowship in pediatric critical care, and the current designation where she is now, she's the Director of Critical Care Medicine at Chris Hani Bara Academic Hospital, where she runs a combined adult and pediatric critical care. She's a pediatrician by qualification herself. She's the immediate past Vice President of the Society of Critical Care of South Africa and past Chairperson of the South African Medical Association's Committee of Education, Science and Technology, also past member of the Ministerial Committees of Health, Technology Management and Revitalization of Emergency Medical Services, and former chair and vice chair of the MAC and Chris Hani Bara. As an intensivist, her interests are diverse, including non-conventional modes of respiratory support of the critically ill, antimicrobial stewardship, pharmacokinetics, and pharmacodynamics of antimicrobials in septic critically ill patients, and ICU also utilization in resource-constrained environments, and also pediatric HIV in ICU and cardiovascular support. So it is a pleasure this evening to welcome Professor Rudo Mathivha to speak to us on the subject long COVID, the post-COVID syndrome diagnosis, public health implications, and management. Professor Mathivha, welcome, and we are here to listen to you. Colleagues are eager to hear about this subject this evening. Thank you. You may, yeah, sure. Thanks, Rudo.
Thank you, Ray, and good evening to everybody. And thank you for that warm introduction. I'm going to try and share my screen now. Please tell me if you can see my screen.
Yes, it's coming up. I can see it here. There it is. Sure. We can see your screen.
Can everybody see it?
I can see it,
Yes.
and I think I speak for everybody.
Yes, go.
Okay. So we're going to be talking about long COVID tonight. I do not claim to be an expert on this subject. I took an interest in it when I got COVID infection at the end of December last year, and come the end of January, I still was struggling to get back into normal life. And I decided to explore this subject and explore therapeutic modalities in an attempt to get myself together. As I say, there are more questions than answers really in this talk and regarding this subject. Okay, trying to find out how I advance these slides.
You can click on the screen, Prof. Click on the screen with your mouse.
I am okay. So in the talk, I'll have a brief introduction, declare any conflict of interest, give a background to the COVID situation, then go into the long COVID subject, where we will work through some definitions. We'll work through the symptoms of long COVID and the proposed mechanisms behind those symptoms. Then we'll talk about the management plans and the implications to our health systems before we conclude. So I want to thank clinics for inviting me to give this talk, and I want to thank the audience for turning out to listen to me tonight. I really don't have any conflict of interest to declare. I'm not paid by Bill and Melinda Gates. I'm not paid by clinics. I'm just coming out to share some information that I know about this. So the COVID-19 pandemic was declared by the WHO in March 2020. And we watched as this virus swept through China from Wuhan. It was an unknown coronavirus. And from there, it rapidly spread worldwide with significant morbidity and mortality. In South Africa, our response was we were a country already plagued by a syndemic environment. And by that, I mean we had a number of epidemics, HIV, TB, poverty, malnutrition. However, in preparing for this, we declared a state of disaster and we went into a hard lockdown so that we went into a state of readiness. This was to prepare our healthcare facilities to be able to receive patients with COVID infection. This was a state of anxiety of the unknown. The effect of the population at large was social, economic, psychological, and health-wise. This was a very unusual setup. We were suddenly taken from being an open society to being housebound, homebound, and suddenly experiencing a new disease. And our government was further challenged on top of the challenges it usually faces. And then we had to face the SARS-CoV-2 behavior, which is a virus that arrived, made people sick, and then suddenly started mutating with emergence of various variants of concern. We went through the first, second, third, and fourth waves, as you all experienced, and the mutations, the parent alpha, then beta, delta, and then now Omicron, BA1 and BA2, now we're on to 4 and 5. As of May 16th, 519 million people had been infected worldwide with COVID. 6 million people had died worldwide. And on the 15th of May, the world was still reporting 290 new cases of COVID per day. Little did we know that we were facing a virus like we had never seen before, a virus that invaded the body by attaching to ACE2 receptors. And that is a virus that attacked every part of the body. So from the heart, attaching to myocardium and causing chest pain, myocardial inflammation, and increased enzymes, and also causing heart rhythm problems. It also attached to the brain and causing what is now known as brain fog, delirium, fatigue, sleep disturbances, depression, anxiety, post-traumatic stress disorder. In the lung, which was the primary system that was affected, we got pneumonia and afterwards dyspnea, chest pain, and cough. It also attacked the pancreas, causing pancreatitis and pancreatic injury, the spleen, decreased T and B lymphocytes, atrophy of lymphoid follicles, the liver injury, increased aminotransferases, and the kidney, renal impairment acutely, and long-term deficient renal function. The GIT was not spared. You went from gustatory olfactory abnormalities to diarrhea, nausea, and sore throat. The blood vessels, you got a microangiopathy, vessel damage, coagulopathy. So this was an onslaught to the human body. So instead of just dealing with a respiratory pathogen, we were dealing with a multi-organ pathogen. So the virus didn't just finish with an acute illness. Evidence is now coming in that there's a range of persistent symptoms that remain long after SARS-CoV-2 acute infection. And this is estimated that 1 to 2 out of 10 COVID-19 affected patients or people get long COVID. The condition is coined long COVID by recognized research institutes, and it affects a wide spectrum of people, those that have had very mild disease to those that have had most severe disease. It involves multiple organs and many systems, including but not limited to the respiratory system, cardiovascular, neurological, gastrointestinal, musculoskeletal, renal, cutaneous, gustatory, olfactory. Long COVID is a patient-made term, and this was published in a BMJ opinion on 5 May 2020 by infectious disease professor who has had 7 weeks of the roller coaster of ill health following COVID-19 infection. It was also coined in a growing number of peer-reviewed articles as the condition long COVID, and it rose to popularity by the use of hashtag long COVID on Twitter. The CDC and NICE guidelines define post-COVID condition or long COVID as individual with ongoing symptoms of COVID-19 that persist beyond 4 weeks after initial infection. While most persons with COVID-19 recover and return to normal health, some patients can have symptoms that last for weeks or even months after recovery from the acute infection. Even people who are not hospitalized and have mild illness can experience persistent or late symptoms. The WHO calls it post-COVID condition, which occurs in individuals with probable or confirmed SARS-CoV-2 infection. It's usually 3 months from onset of COVID infection, so that's the acute disease, with symptoms that last at least 2 months and cannot be explained by an alternative diagnosis. Common symptoms include fatigue, shortness of breath, cognitive dysfunction, but also others, and generally have an impact on everyday functioning. Symptoms may be of new onset following acute infection and recovery from that episode, or persist from initial illness. And the symptoms may also fluctuate or relapse over time. And at this point, I just want to share my personal experience. I had COVID that was diagnosed on the 29th of December, 2021. And I had COVID pneumonia. I was admitted into an ICU, put on oxygen, and I spent 7 days in an ICU and another 7 days in the hospital and released to go home. I was tachypneic and I was coughing and I had extreme fatigue. But what was really scary was the cognitive dysfunction. I would forget where I was going, even in the house. I would forget my siblings' names. I would forget holding my phone in my hand and still looking for it. It was really freaky. But the fatigue was beyond just being tired. It was getting off the bed and walking to the bathroom and feeling like I had done a marathon. And this, on a type A personality person, is like killing them. So it's a very scary thing. When you look at the data available on long COVID, the studies are not many. And there's a reason why. Because most of the patients that come in with long COVID are self-reported. And then a lot of the data on long COVID are from the developed countries that already have support clinics for long COVID patients. There is a lot of data lacking from developing or underdeveloped countries where the health systems do not support that kind of information. So when gathering information on this condition, one was limited to looking at data from studies in developed countries and countries that had support systems for patients with long COVID. So risk factors, we're not sure why certain people get long COVID and others don't. We're not sure yet who is most at risk. As I said, there are more questions than answers. There are criteria groups that appear to be at greater risk: the elderly, women, patients with multiple symptoms during the acute illness. The more multi-organ system affected, the more likely that person is to get long COVID. Pre-existing depression. Now, you may argue that all of us would have had a degree of dysphoria, of depression, going back to the first lockdown, which is a very non-conducive state to be in, given our usual freedom of movement, given our usual not having to wear masks, not having to sanitize our hands at every little corner. We were put in a situation that was unsocial. So that messed up with our minds, with our psyche. So we were not our usual selves psychologically. So we might have had a degree of depression when we got our initial infection, and that has not lifted yet. And we are all at the risk of carrying on that low-grade depression. And therefore, if we get COVID, we are all at risk of getting long COVID. It's an iffy reasoning point. Obesity, and we have seen obesity as a risk for getting severe COVID in patients that have come into hospital. Asthmatics or other pre-existing respiratory disease, and patients who were hospitalized for acute COVID-19 illness. Now, the symptoms and mechanisms. The most reported manifestation is fatigue. The 5-week prevalence is 11.9%. 92.9% and 93.5% of hospitalized and non-hospitalized patients reported fatigue at 79 days post-acute infection. And it's common and persisting regardless of severity of initial disease. The postulated mechanism is that you have psychological and social factors. The factors I was talking about, the hard lockdown, the isolation, the quarantine that plays games on your mind. Then you get the neuroinflammation also playing on the body's responses. You get your pro-inflammatory cytokines that influence the nerve terminals and also work on the muscle fibers. And on the muscle fibers, you get atrophy of muscle fibers. The other thing that they've noticed now is you get microthrombi getting into the muscle fibers and actually forming, causing microinfarcts in the muscles. And that explains the muscle pains that you get accompanying the fatigue. So the sarcolemma damage with the microthrombi. So that's a mechanism that, or the pathophysiology or pathogenesis that is put forward to explain the fatigue. So if one were to address the treatment of the fatigue, it wouldn't just be exercise or physiotherapy. It would also be anticoagulation. It would also be psychotherapy and improving the environment of the patient. Then you have dyspnea. Breathlessness is common in long COVID. The prevalence is 4.6%. Your total lung capacity is affected. Your FEV1 is affected, is reduced. Your functional vital capacity is reduced, and your small airway function tends to go towards bronchoconstriction. Lung function takes time to return to normal after COVID-19 infection. Having said that, there aren't many COVID patients that show signs of chronic lung disease. And the mechanism postulated there is that you get alveolar macrophages and release of cytokines that actually damage the endothelial lining and the microvascular damage as well with microthrombi and collagen and fibronectin formation and microfibrosis in the lungs. And this is put forward to explain the dyspnea. Over time, this resolves. There are a few patients, however, that will get a severe form of this pathogenesis, pathophysiology that will end up with chronic lung disease. Cardiovascular abnormalities, ongoing myocardial inflammation and elevated serum troponin levels following diagnosis. Chest pain due to myocarditis is common 60.3 days following acute infection. And postural orthostatic tachycardia syndrome, POTS, due to autonomic dysfunction. and you might have had patients talk about their heart beating out of their chest. Those are episodes of tachycardia that happen out of the blue due to autonomic dysfunction. You can also get arrhythmias happening also due to autonomic dysfunction. And the mechanisms postulated is that the virus itself attaches to myocytes because ACE2 receptors are highly expressed in the myocardium. So the virus infects the myocardium and causes damage to the myocardium, causes a viral myocarditis that doesn't quite fully resolve. So when the person gets out of the acute illness, they are left with residual myocardial injury and cardiomyocyte death and myositis and a bit of fibrosis and pro-inflammatory cytokines still circulating. And that leaves a residual myocarditis going on. Okay, cognition and mental health, and this is what we refer to as brain fog, as though you are walking in a swamp with a lot of fog and you can't think straight. It's common and it's debilitating. You have a persistent headache. Stroke is common. Post-traumatic stress disorder is common. Neuropsychiatric disorders are common. Depression and obsessive compulsive disorders. Insomnia is common. Anxiety disorders are common. And the mechanisms postulated there are neuronal toxicity due to pro-inflammatory cytokines, self-perpetuating neurotoxicity, anti-inflammatory cytokines that don't really balance out the pro-inflammatory cytokines, and you get a pro-inflammatory triggering from the COVID-19 in the acute phase, and you get dying neurons. Also, you get a vascular component where you get extravasation of blood-derived substances, things like high glucose, calcium, and highly reactive oxygen species that extravasate from the blood are noxious to neurons. You also get microthrombi forming in microvessels in the brain, causing local microinfarcts and autonomic dysfunction. All this is put forward as explaining the cognitive dysfunction. We don't know how long this lasts. We know that delirium does occur. It does get better over time, but this is a new disease. It's a young disease. We don't know, we're only 2.5 years into this disease. We don't know if this debilitating neurocognitive dysfunction is going to be debilitating going forward and will leave permanent injury to the brain, the heart, and the muscles, or if it will get better with time. Other common symptoms are multi-organ impairment. This would follow if we looked at the acute affectation of the multi-organ systems. Acute kidney injury leads to decreased renal function at 6 months. Acute pancreatitis that can lead to permanent pancreatic injury and therefore give rise to diabetes. Spleen function is affected and may therefore have a bearing on the immune function of the patient. Gustatory olfactory, we've heard about the taste and smell losses that may recover after time. With some patients is after 2 months, with some patients at 6 months, they still don't have the taste and smell back. We have indirect damage to the liver, muscle, and blood vessels and skin. So you may have rashes, you may have ulcers to the skin. With blood vessels, you get microthrombi, you may start getting what looks like blood vessel insufficiency that may also manifest on the skin or start manifesting as deep ulcers. Okay, subacute thyroiditis. This is a complication that I had, and I had to go on to thyroxine supplementation. Management, we start with diagnosis. This is hard because there are many other conditions that can present with the symptoms we just described. However, there is a diagnostic code for long COVID. It's an ICM-10-CM diagnosis code U09.9, and it stands for post-COVID condition unspecified. And our medical aid schemes will pay for that. But you need to rule out a lot of other conditions that may present with fatigue, myalgia, like chronic fatigue syndrome, like your uncontrolled comorbidities, depression disorders, anxiety disorders, other viral infections, bacterial pneumonias, TB. So you would need to do a thorough examination, rule out any acute life-threatening conditions before you settle for long COVID. Do a full lab profile, your full blood counts, UNEs, LFTs, etc., to exclude any acute life-threatening condition or any other common condition that is treatable. Treatment should be a multidisciplinary approach, from primary health care to specialist care. From the symptoms that we've described, you might have already seen that we're going to need the primary healthcare practitioners, the general practitioners, and specialist care. We will need physicians, cardiologists, we will need neurologists, we will need psychiatrists and psychologists, and we will need the allied healthcare workers, the occupational therapists, physiotherapists, and the mental health environment will be very important. And in our country, that is going to be a problem because we already have mental health care facilities challenge. Then we need rehabilitation centers, okay? We also need the patient to do a self-appraisal and self-management. We rely on the patient to give a lot of feedback here, to tell us how they're feeling, self-report. There is no specific pharmacotherapy for this condition. We need to maintain a national database of the condition so that we can plan and allocate for resources, just as we do for HIV, TB, and other notifiable conditions. The prevention is public education about the existence of the condition. Vaccination, this is very important because vaccinated people do not get severe disease, and those that do not get very severe disease, that do not get hospitalized, are less likely to get long COVID. We still promote the NPIs during surges. This is an example of the NICE guidelines on how to approach managing long COVID. So if you suspect it and you can work out that the person got COVID, you need to review that person at 6 weeks and see if you can pick up the symptoms of long COVID. And you assess people with new or ongoing symptoms, and you discuss the person's experiences. Do not predict likelihood of long COVID based on acute symptoms, and consider gradual decline, frailty, or dementia as a sign of long COVID, and use cognitive screening tools. Investigations and referral, offer tests depending on individual needs, exercise tolerance test, blood pressure and heart rate recordings, and chest radiograph. The chest radiograph may not be that helpful here because it doesn't correlate with the dyspnea it doesn't correlate with the acute disease, and consider referral urgently if required for people with psychiatric symptoms, because a lot of these patients will tell you they're feeling suicidal. When that fatigue hits you and you cannot do anything, you just feel like doing away with yourself. And you still consider ruling out life-threatening conditions, and you refer to a multidisciplinary assessment service from 4 weeks after start of acute COVID-19. And you can see already here, it's a challenge for us, for our public health care services. We don't have the infrastructure to actually meet these requirements for our patients. And when we're planning care, we don't have multidisciplinary teams at primary health care settings. We struggle to have multidisciplinary teams at district and secondary care hospitals. We haven't actually settled on a definition for long COVID in children. And that is lacking in the support for long COVID. And follow-up and monitoring that needs to be done quite regularly and see if the symptoms are relapsing. We would have a problem, but this is a very nice plan of managing a long COVID problem, and then sharing your knowledge and skills and training between services, and help practicing to provide assessments and interventions, and agree to local integrated referral pathways. This is a very logical way of managing long COVID, but I put it up here as an example of how organized we would have to be, what kind of an infrastructure we would have to manage long COVID. And it is important that we actually start getting our tools into gear, because we're facing an evolving disease process on a large scale. 10 to 20% of over 3 million people could potentially present with long COVID at our healthcare services. So these are the number of people that have been documented as having COVID in South Africa. And that is a conservative estimate, because not everybody that has had COVID has been tested in our country. Our primary health care is not optimized, nor streamlined. Our public health infrastructure is ailing. Do we have time to plan? If we're facing an evolving disease process, and this is not acute COVID, where we had to think on the back foot, this is something that's evolving. I do think we have time to plan. And if we could jack our public health care infrastructure up, we would have time to plan for this condition. We are, however, faced with other chronic disease burdens. We have a skills shortage, and our decreased human resources face a burnout syndrome and moral distress. We still need to responsibly manage scarce and expensive resources, whilst improving access for all legitimate citizens to health care. And this is the situation in our country. If you could guess these headlines in our local newspapers, you would think maybe they were from a year ago or 6 months ago. These headlines were actually from 1999. We have been in trouble with our public healthcare sector for a very long time. So COVID isn't the thing that tipped the ship over. We have been in trouble since then, and we just haven't been paying attention. And now we are sinking deeper, and disease processes will continue to come and go. We have COVID, now we have long COVID, on top of HIV, TB, poverty, malnutrition. And at some point, something has got to give. And it's up to all of us to roll up our sleeves, to turn on our thinking caps and fight for our healthcare services. We are a country of such inequalities. First world development, informal settlements, and somewhere in the middle development. We deal with disease processes that come from lack of sanitation, lack of water supply, lack of electricity supply, to diseases of lifestyle. But COVID has shown us that nothing will protect you when such a pandemic arrives, because it knows no class, it knows no color, it knows no wealth, and it will affect all of us equally. So we all need our health systems to be jerked up. So in conclusion, many people are infected with SARS-CoV-2, and the long-term implications are concerning. We have identified some possible risk factors for development of long COVID. The condition is still evolving, but it's an enigmatic condition. We're still elucidating the pathophysiology, and we do not have proven therapeutic strategies in place. Perhaps we have time on our side to set things the right way, but we worry about what impact the emergence of new variants of concern will have on the incidence and severity of long COVID. Research into understanding of pathogenesis, risk factors, symptoms, and therapeutic strategies of long COVID may help to reduce strain on and demand on people with the condition and the healthcare systems that will support them. And a consensus on a single common definition would be good worldwide, as we would be able to compare the incidence of this condition across countries, and the management strategies could be applied across countries. Thank you. I'm done.
Thanks very much, Rudo. I think it was quite a nice, crisp, but quite with lots of information that you have shared with all of us here this evening. And there's no other way of describing the presentation as what I've seen posted earlier on by Dr. Desai. Excellent talk, but scary. But I think scary in the sense that we still don't know much about what's happening with COVID. As you say, that we may still be going through a long process, and there are certain things that need to be done. What you spoke about public health, that is important, that we need to be prepared to manage even the new emergence of new variants if they will occur. But thank you very much for this talk, and we have quite a number of questions that have been posted on the chat line. We also want to request that any of the colleagues who are here who need to ask other questions still have time to post your questions on the chat line. And we have quite a number of colleagues from different disciplines who are here. So let's make this an engaging discussion. And those who've walked this journey on COVID management, all of us have actually. Those who've done much more discussions or research can share information, but primarily Professor Mathivha will be answering the questions that have been posted in the chat line. Going first to this question by Dr. Desai, that it's quite a scary talk. We've all been scared in many cases. How long does anosmia last, and is it selective, that is for good and bad smells? I know someone responded earlier on, but can we just have, I think Dr. Kleinhans means nothing, let's leave it, let's take that question first. Anosmia?
Do you want me to answer?
Yeah, we'll take them as they come. Yeah.
Okay, so the lack of smell lasts for a varying period of time. And the longest that I could find in the literature was 8 months. And it doesn't distinguish between the smells. but the stronger smells seem to return first.
6 months, and the strongest return first.
Yeah.
Thanks for the response. We've not been picking this up with the recent infections. Any reason, or the variants differ?
Omicron is highly infectious, but doesn't seem to be that great in causing severe disease, especially in vaccinated people and people that have had previous COVID infection. And I don't know if it's inherent in its pattern of mutation. Maybe we can ask the virologists that, but we haven't seen a lot of patients presenting with smell, the loss of smell.
In the recent past, yeah.
Yeah.
Dr. Sneeman wants to know, recently dizziness has been described as a very common long-term sequelae. Can you confirm that, dizziness?
Yes, it forms part of the neurological dysfunction. The neurological, I put it down as cognitive dysfunction, but it's actually a neurological dysfunction, and it's a whole spectrum of central nervous system and peripheral nervous system dysfunction. So from olfactory to auditory nerve affectation, one can get a whole spectrum of neurological dysfunction.
Okay, no, thanks a lot. Dr. Rankin wants to know, do corticosteroids, inhaled or oral or IM, and anticoagulants during the acute phase help to decrease the risk of developing long COVID?
The answer is no, but anticoagulants have been shown to help patients with severe fatigue. And this has been seen in real life, where they've been treating patients with extreme fatigue and muscle pains, and giving them anticoagulants has helped with the muscle pains. And this addresses the microthrombi that I was describing, were seen in muscles of these patients. And when you take that element out, you don't get the micro-infarcts, the repeated micro-infarcts and little pieces of muscle dying. And that and analgesics seem to have a synergy of working together.
Okay, just for clarity, in terms of long COVID, is it seen mainly in those who had severe disease, or even others who may be symptomatic but didn't require hospitalization and could manage at home? Is there differentiation between the two types of patients?
So most studies suggest that even if you had mild disease, you would still be likely to get long COVID, although we cannot identify who is going to get long COVID. So you don't necessarily have to have had severe disease to get long COVID. And this is the scary thing in our country. We've got thousands and thousands of people out there that have had COVID, that have never presented at a healthcare institutions, that will come in with these common described symptoms of long COVID. And this is what worries me, that we may have a massive onslaught of patients that present with long COVID that we were underestimating may come. So it's from mild disease to severe disease. We see, it's seen more in people that were hospitalized for their acute COVID infection. But if you've had mild disease, it doesn't rule you out. Doesn't mean you won't get long COVID.
Yeah, that's scary. And Dr. Mathivha wants to know, how do we differentiate COVID pneumonia from other pneumonias like streptococcal pneumonia or other viral pneumonias?
If you're COVID positive, the default diagnosis, and you've got pneumonia, the default diagnosis is COVID pneumonia. We obviously would run a respiratory viral panel and look for bacteria. if we don't come up with anything else, you've got COVID pneumonia, as happened in my case. There was nothing else that could be found.
Yeah.
And yeah, I was COVID positive.
Yeah. And Dr. Mashir, welcome, Dr. Mashir. It's been a long time. Will pediatric long COVID may be the same as in adults? Now that in the last 2 waves or so, we've been seeing more of the pediatric cases being admitted in hospitals. Have we found that the children also have long COVID the same way as adults?
So it's going to be interesting in children. The kind of child that we've been seeing presenting to hospital who is COVID positive has been the kid under 10 and more commonly under 5. And we have also been seeing a spike in malnutrition. So what criteria are we going to use to diagnose long COVID in those kids? If they're malnourished and they become lethargic and they present with myocardial abnormalities, because these are abnormalities that you can see with severe malnutrition. And these are children that cannot pronounce what it is they're feeling. Because a lot of this hangs on self-reporting. So the criteria in kids still have to be elucidated. In the older child, the adolescent, those will be able to communicate what it is they're feeling. And we may be able to work out what constitutes long COVID, what doesn't.
Yeah.
In the toddler and the younger kid, that is going to be difficult. And I think that's why up to now, we don't have a consensus on the definition of long COVID in that age group. Dr. Mashiko is right. The kids that we have been admitting into the COVID ICU have been under 5s with COVID pneumonia. And the risk factors there are that this is an unvaccinated age group. And we're now seeing the vulnerability of this age group to COVID, even though it's Omicron that has been declared not vicious, it is quite deadly in this age group.
Yeah. And it's a pity that we don't have a vaccine for those under 12 at the moment.
Yes. But I think they're working on it. I think Pfizer is working on it. But it's a difficult situation with cases of myocarditis having been experienced with the Pfizer vaccine in the 12 to 17 age group in male children. So parents are going to be a little bit iffy about that, but then you have to take the number of cases that actually got myocarditis. It's the same thing as those thrombotic episodes in the female adult patients.
Yeah. Here's another interesting question from Dr. Kleinhans. Is there another example of a novel virus that went from being pandemic to endemic that we can look at for learnings on the potential post-virus syndromes and their future prevalence, so that we can say that it's endemic and COVID now, SARS-CoV-2 infection can relax and say, we get into an endemic situation. And because of previous infections of other pandemics that we've seen in the past.
So the closest I can think of is the influenza pandemic of the 1920s that really killed a lot of people and then went on to be a seasonal disease. And we know influenza can be associated with chronic fatigue syndrome, post-viral fatigue condition. And we're hoping, and we're not there yet, that COVID may evolve down to being one of those viruses that will become endemic, and we might start seeing it occurring seasonally. And this is just a hope. I don't know if it's going to behave that way. It's still mutating too much, too fast. And as you can see, it wreaks havoc in different parts of the world. The Omicron BA4 and 5 wreaking havoc in New York and in the UK, whereas we had it in South Africa and we didn't really sweat it too much, but the unvaccinated amongst us did struggle with it. So the question of when it is going to give us a breather, one doesn't know. I think we are right now officially in its 5th wave, but nobody wants to call it.
Sure.
Yeah.
Yeah. In terms of admissions, in the first wave, well, after perhaps more the second wave, that we started saying everyone being admitted, all admissions in hospitals, there should be a test. What's your view now that once we move to an endemic situation, should we be doing routine tests for COVID or screening for admissions?
This is a difficult question to answer because there are many ifs. We are not in an endemic environment. And if we suddenly stop testing people, we are wishing ourselves into an endemic situation. In our non-COVID ICU, we still screen every request for an ICU bed for COVID. And we do that because we have a COVID ICU as a support ICU. And if they're positive, they go there. If somebody comes for emergency surgery, we screen them for COVID so that they can be attended to in a COVID theater. My personal preference is still to screen patients for COVID if they're seriously ill and they present with respiratory symptoms, or they present with a headache and a high fever. And I do understand the resources problem. I do understand that people wanting to get on with life. I do understand the protecting of the economy, but the healthcare worker in me says I cannot ignore the fact that we still have a problem. So I think at the moment it's institution to institution making a policy. Until the Department of Health says this is a blanket policy, every institution has to have a policy for themselves.
Yeah. As you say, we are all learning at the same time at different levels, different pace, and our environments may differ or may not be the same. I see Prof. Langer's hand is up. Chris?
Hi, Rudo. Nice to see you.
Hi.
There's a very good article in Anesthesia from earlier this year and it's based specifically on the Omicron variant and on suggestions for elective surgery. Clearly, in asymptomatic patients, or I think if a patient's got respiratory symptoms, it's a no-brainer that they must be tested for COVID in the current era. But the whole issue of somebody who's maybe a bit flu-y or, without the respiratory symptoms, what do you do with them? And if they test positive, how long do you wait? And the guideline in that particular article was 2 weeks, providing they're not symptomatic after those 2 weeks. But it's a very, very good article, and I'm happy to share it with Dr. Bila because they emphasize the importance of weighing up what the patient's there for, what treatment they need, what surgery they need, against if they have, asymptomatic COVID, you weigh up as a risk-benefit issue with each individual patient. And I agree with you. I think each hospital needs to draw up guidelines. But I'm happy to share the article with Dr. Bila if anybody's interested in it.
Yeah, that's a very good point. And we are carrying out such a practice at Barra. The problem is we neglected other disease processes in the heat of the moment of the acute COVID pandemic days. And now we have to concentrate on everybody equally. And when we get patients, all patients, we have to try and not contaminate environments for other non-COVID patients. And that is why we screen patients. So in our ICU, in the non-COVID ICU, we try and keep that ICU clean of COVID, because we have a COVID ICU that can accommodate patients that test positive. So patients that are coming for elective surgery, yes, we will test them. And if they're positive, we have a COVID theater. They will get attended there. If they need ICU post theater, they go to COVID ICU. If they don't need ICU, they go to a COVID surgical ward. So this is the policy that we've got at Bara, which emphasizes each institution having a policy. If you've got the space, then use it that way, repurpose spaces. Because if I suddenly contaminate the non-COVID ICU, I've got nowhere where the non-COVID patients can go post-surgery, or those that need ICU, the DKAs can go, because I run a risk of infecting them with COVID, and they're very vulnerable at that point in time.
Okay, thanks for that response, Rudo and Chris. Were you then? I think Prof. Nangal said he will share that document and will share it with everybody who was registered for this webinar this evening. It's quite an interesting topic this evening. We still have lots of questions to go through. Dr. Williams-Ashman, are there any emerging biological markers that support the diagnosis of long COVID?
Nothing that is solid. They are looking at cytokines. If they remain elevated, IL-6 is the big one, but that is just a marker of ongoing inflammation. And it's no. But so experts can tell us. Yeah.
Okay. Yeah. Well, as I said,
in the myocardium, it's your troponin.
Mm-hmm.
You know, that can be raised for a long time. That just indicates that you've had myocardial damage. So you can measure those in somebody who's got cardiovascular symptoms. Muscle enzymes in somebody who's got fatigue and muscle pains. That just shows you the organ that is involved. But it isn't specific to long COVID. It might just help you to see which end organ is mostly affected. And if you go back to the postulated mechanisms and maybe understand that it might be microthrombi, and then you kind of up your anticoagulation and see if that comes down, that biomarker comes down, then you know you're addressing the correct pathophysiology. But they're not specific. So that's why I said no.
Yeah. Now that you've mentioned anticoagulants, which anticoagulants should be used? I mean, you spoke about anticoagulating those patients.
Okay, people are using anything from cardiovascular aspirin to the newer generation anticoagulants. I used warfarin because I was already on warfarin for a clotting factor deficiency. So we just upped the dose on my warfarin and targeted the INR much higher.
Yeah.
So it depends on whoever is looking after you, which one they want to go with. Most of the patients are just given CVS aspirin. It's easy to give.
Yeah. Sure. There's been a recent study, or maybe in the article that I read, about aspirin, just using, I'm not sure if the cardiologists here can comment on that use of prophylactic aspirin, with the usefulness thereof. I know it's been standard that we should be used now, but now there are studies that seem to be coming up not to supporting that idea. I'm moving away from now that you mentioned
But in long-COVID patients, it wouldn't be prophylactic, it would be therapeutic.
Yeah. No, not in non-COVID patients, yeah.
Oh, in non-COVID patients,
Yes,
that is out of my league.
I'm just mentioning that. I'm sure the cardiologists are here can talk about that. It's something that has come up that I just read recently. There's quite a number of people quite happy about the presentation. Now we're going to vaccinations. I skipped a question about Kawasaki. Maybe let me go back to it. In children with Kawasaki-like symptoms or disease may be followed up, and can they be detected? Can you detect symptoms and signs of long COVID?
With MIS, it's too early to tell, and we don't really have enough patients that have been evaluated for long COVID. It's the same thing I was saying about the younger kids.
Yeah.
And the MIS kids often have cardiac problems. And are they lethargic because of their heart problems, or is it long COVID? The jury is still out on that.
Yeah, no, we have seen somewhat still to read a lot about it. Yeah, vaccination in terms of long COVID, are they effects of vaccination on long COVID after you've had a breakthrough infection?
So vaccination seems to be protective in that you are unlikely to get a severe or significant infection if you've been vaccinated. And they actually recommend that patients with long COVID get their booster shots. Okay. So I really don't know how that works, but it is recommended that you keep up with your booster shots.
Yeah.
They recommend vaccination quite strongly.
And yeah, booster, yeah.
Yeah.
I will not go into the controversies about people saying, when are we going to stop? Because there's going to be booster after booster. When do we think that will stop?
That's not up my alley. I don't know.
Yeah, perhaps this may be the last question. How does anticoagulation help for chronic fatigue? I don't know if you said that.
With the chronic fatigue syndrome? Or with...
Yeah, I think that's not what Dr. Desai is implying in this question.
I don't know. I've just addressed with fatigue in long COVID. I don't know. Chronic fatigue syndrome remains an enigma, and nobody knows what the mechanisms of pathogenesis behind it is.
Yeah.
So everybody's still studying that condition.
Yeah. And
there isn't like any evidence-based therapeutic strategy for chronic fatigue syndrome.
Sure. There's somebody has raised his hand, Dr. John Cullen. I hope I pronounced the surname correctly. If you can unmute yourself and make your question, ask the question or comment. John? If you can unmute yourself. Is it John Cullen who has raised their hand?
John Callahan.
Yeah.
And can you hear me?
Oh, yeah, now we can hear you. Sure. Go ahead.
I'm an ear, nose, and throat surgeon. I have a patient who it's almost 9 months now. She's extremely tired, as we have heard, and she's hoarse, and finds it very difficult to speak. She can speak for about an hour, and she becomes completely aphonic. Now she has insurance for disability. Will this long COVID end up with a disabled person able to get insurance?
Yeah.
Disability.
Yeah.
A disability, yes. That she's so disabled that she cannot continue with her work. And now it's a question of, I have to certify that this lady will probably be permanently disabled. Is this, can you just elucidate that a little bit and give us some guidance?
Look, you have an ICD diagnosis code, and you can motivate, if you're motivating on the fatigue, from the fatigue angle, and if you've got other systems involved that interfere with daily functioning, you could probably swing it that way. Because it's post-COVID condition unspecified. It is recognized to interfere with daily functioning. The problem is how long the disability is for, because disability suggests that she'll never be able to do normal daily functioning.
Yeah, sure, definitely. Yeah, I think that should be the approach. I don't see further questions there. Yeah, I think that brings us to the end of the Q&A. I don't know if Dr. Makoti, you want to speak? Or it's just moving. Okay, Dr. Mohammed says you can qualify for temporary disability. Temporary, sorry.
Temporary.
Yeah, I think that's the answer.
Okay.
We'll have to be reassessed annually to see if this is permanent or not. Does her work require to talk? I think those are the issues to consider when you write a permanent disability for the patient. I'm going to ask Professor Jova Rieva, one of our elders who's working with us in our risk committee in clinics to make the final comment and also do a vote of thanks for us.
Good evening, Professor Mathivha. Nice to hear from you. And I was delighted and enjoyed your presentation on a very difficult topic, and a topic where we don't have many answers yet. So I think it was an excellent one. The other interesting point was that you made a remarkable recovery from your episode of COVID-19. You mentioned that you had brain fog. Now, what comes out in a positive manner is that you are able to think clearly, and you can make such a comprehensive presentation despite the fact that you had brain fog in the past. So you recovered completely from the brain fog. And I am delighted about that, because you can continue doing excellent work. So that was a very positive sign that brain fog is not often a permanent thing. What is of interest about the brain fog and that is that they have found certain antibodies in the brain, autoantibodies. And whether this disorder is an autoantibody type of phenomenon, which is transient, we don't know. There's lots about it we don't know. And there is a very major study that that isn't complete, but that was in preparation to look at a very large number of people who had long COVID and to try to get a better understanding of it. As far as I know, I haven't heard anything further about that. The one issue that has come out, someone asked about children and vaccine. And I think about a week ago, the NEJM presented the findings of 6-year-olds plus who were vaccinated, and the findings were positive in terms of prevention against COVID-19. So that is it. But there are other interesting points. I was just looking at this week's NEJM, and now they also have a combination of B123 and Delta virus, and they call it Deltacron. So we don't know where we are going. And also the issue about does COVID, this Omicron, give rise to the same sort of long-term effects, such as the long COVID. And I haven't come across anything in that regard, whether that can happen. All I can say is that whilst I ended up with COVID, I've just recovered from it. My wife has in fact lost both smell and taste and I'm sure that hers also was probably an Omicron. So it seems that these things can happen with the variants too. However, I must say that what you have put across had also far-reaching consequences on our health system. And not only on the health system, but also its impact on inequity that is so rampant within our country. So I think I'm hoping that your presentation and all that should go to the authorities, the health authorities, to the minister, so that we can take into account the consequences of this pandemic. By the way, long COVID is in itself possibly a pandemic. It's in itself. So I think that all in all, what you've put across has been very helpful. And I would also suggest that all our listeners get hold of the NICE guidelines. The NICE stands for National Institute for Clinical Excellence. And this is probably the best guide anyone can have towards attending to patients who have the long COVID. So once again, Professor Mathivha, it was a very impressive and an excellent overview, which is comprehensive on long COVID. There aren't many overviews as extensive as yours. And thank you on behalf of the clinics group. And we hope to get you back again for other talks in the future, because you have the ability of presenting things in a very clear and concise of manner. Thank you and good night.
Good night.
Thanks, colleagues. Good night. Thanks for attending. Hope to see you again next week for another interesting discussion. We're going to be discussing some medical legal issues next week. Thanks, and thanks, Prof.
Thank you.
Thanks, Zuki, in the background. Have a good evening.